Hello, everybody. Dr. Al Heuer here. Just another one of our lectures that are online. I want to welcome you all. Thank you all for attending today, and thank you guys. If you're newcomers to our presentations, thank you. If you're loyal supporters and you've been with us before, we thank you as well. So this presentation is on ventilator pressures and graphics, and it's a variant of a presentation I gave at Morristown Medical Center, where I'm still employed full time as lead adult ICU therapist. There was a, if you will, a request by some of the nursing staff as well as the trauma physicians to just go over more on things related to ventilation pressures and graphics. So here goes. Let's take a look at some learning objectives. So some of the specific objectives or specific topic areas that we're going to look at include reviewing various ventilatory pressures. There's some key pressures that we're probably all familiar with, but then there's others that have really evolved, or they've emerged as pressures that are particularly important, not only to monitor, but to try to keep beneath certain thresholds or within, if you will, a certain range. We now know that certain, if for example, plateau pressures exceed 30 centimeters for any protracted period of time, that can induce or contribute to ventilator-induced lung injury. So that's just one example. We'll take a deeper dive on that. We'll examine some strategies to actually manage some of the pressures. So, we don't have to just let the patient be victim, if you will, to some of those pressures. And there's things that we can actually do, manipulating either, again, adding a therapy to the patient, or actually manipulating the ventilator parameters in order to try to help normalize those pressures. Describe pulmonary mechanics and techniques to manage them. Review the basics of ventilator waveforms. So one of our colleagues, Tom Petty, actually gives multiple presentations on waveforms. In one of the textbooks that I edit, Egan's Fundamentals, we actually have a chunk of a large chapter that's really dedicated to waveforms. So, I probably won't do waveforms as much justice as what I'd like if we had more time, but I think that this presentation will cover some of the major areas that we need to focus on. We'll examine some strategies to manage waveform abnormalities. We'll review some cases or some case examples, and then probably most importantly, we'll provide you with additional resources if you want to drill down and learn more about this stuff. You guys have learned, probably when you're in school, if you've done other continuing education. I recently renewed for the adult critical care specialty, and I can tell you that the exam still very much emphasizes ventilator waveforms and pressures. So it's something that's really, key to the foundational education we got, but key to also keeping current, because again, there's a lot more information that we know now that we didn't know a decade or two. So some of the key ventilating pressures that we're going to focus on over the next 45 or 50 minutes, peak inspiratory pressure, or PIP, which is probably, we really thought at one point in time it was one of the key pressures that's important. It's still important, but we now know it's less so. It's less so than some of the other pressures that we'll be talking about. PEEP, or positive end-expiratory pressure, again, sometimes for your spontaneous breathers referred to as CPAP, but basically PEEP is the term we use if a patient has an artificial airway and is mechanically ventilated. Mean airway pressure, which has really emerged as a quite important pressure. Plateau pressures even more so, driving pressures as well. So the one important facet of this slide is that plateau pressures and driving pressures are two of the pressures that over the past decade, 15 years or so, we now know are really critical in order to try to optimize the breath delivery to the patient and minimize the chance in doing so of causing them harm. So I've ruthlessly borrowed this depiction from ARDSNet, okay, and that's kind of like the middle of the screen there where you see ARDSNet. So there was a study that was kind of a sentinel study that was actually published in the New England Journal of Medicine in the year 2000 that basically said that, you know, the tidal volumes that we're using, the larger tidal volumes that we're using on patients until that point in time were injurious. So the study actually looked at, you know, delivering basically breasts that were, you know, basically 12 mLs per kilogram versus 6 mLs per kilogram. And what they found that the lower tidal volume, the 6 mLs per kilogram patient population in this study did much better. The mortality was 31% versus almost 40% for the larger tidal volume group. And that kind of that was an important study. It was kind of a large study. They had about 700 or 800 participants that were randomized into one group or the other. They did interim statistics. I'm not trying to bore you with all this gory detail. All that meant was, let's not wait until the study's over. Let's see if one group is doing better than the other while we're still studying them, okay? And what they actually did, they did these interim statistics, and they found that the lower tidal volume group was doing so much better that they actually, it was ethically inappropriate for them to keep the larger tidal volume group getting that larger tidal volume. So they actually crossed them over. It's called a crossover provision. They crossed them over to get the lower tidal volume. The significance is not just tidal volumes, but the subsequent work that's been done related to ARDSNet. Okay, so really reducing the chance of us harming a patient who's receiving mechanical ventilation because they're on mechanical ventilation. So in addition to using lower tidal volumes, we also use, you know, recommendations are more liberal use of PEEP, more liberal use of PEEP. The one thing that they found out, or one of the major findings that they discovered with lower tidal volumes, is that there was a higher incidence of atelectasis, because now you're delivering these smaller breaths into the patients. So they started coupling the lower tidal volume with, if you will, higher PEEPs. And this is, again, right off of this slide, or this depiction has been on ARDSNet, on that NIH site for probably almost 20 years, but it still applies. It's been basically supported by the subsequent evidence. Notice the bottom portion of the table that's there, and it's called higher PEEP, lower FiO2s. So the second to the bottom table, it's actually showing you the use of 10, 12, and 14 of PEEP with a patient who's on 30% oxygen. So one of the things that I'm kind of a stickler with in the ICU is the intensivists are sick and tired of hearing it, but they've kind of come a little bit in my direction. And that is that we probably underutilize PEEP, and we set it in an arbitrary manner. We used to set patients when they came up from the OR, or came from the ER, trauma patients, or, you know, they came from you know, the recovery room, et cetera. We put them on 5. Now our starting point for most of those patients is 8. It's really like a protocol. We just go with 8 for all kinds of reasons. It was a first step in not being so arbitrary in setting all these patients on 5 of PEEP. Okay, that some of these patients really look like they could benefit. You know, just in terms of their x-rays, in terms of their oxygenation, in terms of the guidance we get from ARDSNet from starting them up on higher PEEP. The other thing too is that we found that some of the patients, particularly ones that were coming from the OR and the recovery room, were also de-recruited, that they were on anesthesia machines and they had inadequate PEEP. So we actually found some benefit there. The final thing is that we had found that of our ventilator associated events, VAEs. So I'm just going to give you a paraphrase the definition of a VAE. It's not a VAP, but it's sort of, it's like a precursor to it. It's like VAP light. It's really identifying patients that may be headed towards developing a VAP, where their oxygenation needs have gone up abruptly. And it really looks at an increase after a period of stability on the ventilator, an increase in the FiO2 of 20% or more, or an increase in PEEP of 3 or more. And we found that we were increasing the PEEP. Once the patient came up and was stabilized, we found that we were increasing it from 5 to 8, 5 to 9, 5 to 10. And we found out that probably a third of our VAEs, which are now reportable, were attributable to that phenomenon, going from 5 to 8 or higher than that. By picking a starting point of 8, it may sound like it's kind of manipulating things a little bit, but 8, number one, seem more appropriate. And when we do go up, we go up in a stepwise fashion, and typically we're going to 10. And seeing how they do there, obviously drawing a gas and seeing how their pressures are and things along those lines. So just keep in mind this, that you have ARDSNet that's available to you, number one, and number two, that if you're starting all your patients on 5 a PEEP, you may be under PEEPing them. Further, if you're not using some of the tools that are available, a few of which we'll go over today, that can help guide the appropriate use of PEEP, then you probably should be. It's something that you actually want to look into, and this presentation will help arm you in order to be better equipped to do that. So mean airway pressure. So this is one of the first ones that we're, so peak airway pressure is what it sounds like. It's a descriptive term. So it's, you deliver the breath to the patient. It's a reflection of what we call total impedance, which is the combination of resistance and compliance. Okay, total impedance. So that's peak airway pressure. It's not insignificant. We certainly can get twitchy when peak airway pressures are starting to, approach and exceed 40 centimeters in adults. But again, what we now know, it's less commonly implicated in what we call ventilator-induced lung injury than some of the other measurements that we have. Okay, and some of those other measurements are this slide here. So mean airway pressure. So it refers to the average, or essentially the average pressure applied during positive pressure mechanical ventilation. It's one of the major components to calculate what we call oxygen index, or OI. Okay, and Terry may have gone over some of this. I know he gave a good presentation on ARDS, so I'm sure that he has gone over some of this as well. But the OI, oxygen index, is the mean airway pressure times the FiO2 times 100 over the PO2. And just order of magnitude, a lower OI is better. The targeted, it would be typically less than 20 to 25. Now, at the hospital that I work at and other places as well, P to F ratio is used, it's one of the measurements that certainly has value. So you're looking at, in a P to F ratio, the P, or the numerator, the top number, is the partial pressure of oxygen per an ABG. Okay, the F is the FiO2 expressed as a decimal. So 50% oxygen would be 0.5. All right. So the bottom line, the lower the P to F ratio, no bueno. So when your P to F ratio starts getting south of 150, no bueno. It's one of the major criteria that are used to determine, if you will, ARDS, acute lung injury, or acute respiratory distress syndrome. But it's also used to basically determine, the level of oxygenation or the impairment that exists. And again, crudely put, 200 to 300 would be like acute lung injury, or per the Berlin definition would be mild to ARDS, provided it's accompanied with a crappy chest X-ray and high poor compliance, high if you will, plateau pressures and things along those lines. Okay, but just circling back, one of the major flaws of a P to F ratio is it does not consider PEEP. Okay, a major component. So OI, or oxygen index, may actually be more valuable than a P to F ratio. And one of the major contributor to mean airway pressure is in fact PEEP. Plateau pressures, so per ARDSNet, the goal is to maintain a plateau pressure of equal to or less than 30 centimeters, preferably equal to or less than 25. Okay, now not just for our ARDS patients, but like even our COVID, whether it's non-COVID ARDS or our COVID patients, in some cases it was simply not practical or possible to achieve a plateau pressure of less than 30. The guidance there is, once you've done, once you've reduced the things like the tidal volume to as low as 4 mLs per kg, you've tweaked the whether it's the inspiratory flow or the I time in order to deliver that breath more kindly and gently, et cetera, et cetera. In some cases, you just need to accept for a period of time a plateau pressure that's north of 30. The point of it is, though, is that your goal is to get it at or below 30, preferably at or below 25. It's implicated as a major contributor to VILI, again, or vent-induced lung injury. It's measured by performing an inspiratory pause, which basically all state-of-the-art mechanical ventilators, invasive mechanical ventilators have the function in order to do that. It's used, one of the primary determinants in calculating static compliance, okay? So you're doing the inspiratory pause because you don't have that, you don't have airflow. And airflow, or if you will, an impediment to airflow is the very definition of resistance. So you're really kind of delineating. When you have a high peak airway pressure and you're trying to delineate, is it resistance? Is it compliance? You obviously want to look at the patient's total clinical scenario. But one of the key determinants would be to do an inspiratory pause and to see what your compliance is. The difference between your if you will, your plateau and your peak, basically divided by your flow in liters per second is going to give you your resistance. So it's going to tell you, it's going to give you a good idea as to whether or not it's a resistance issue and the patient has things like mucus, or they have bronchospasm, or they have a kink tube or something along those lines, versus a patient who's either chest wall or lungs are becoming stiffer. And again, some of the things that you can do, the basic strategies that you can employ in order to, if you help manage to get that plateau at or below 30, is coming down on your tidal volume in a stepwise fashion. Obviously you want to keep your close eye on ABGs. You may have to tolerate do permissive hypercapnia, where you're tolerating a creeping up a PCO2, because now maybe you're ventilating the patient less. But if they have relatively normal kidney function, they should be retaining a bicarb and able to eventually buffer that and keep the pH at or north of 7.35. Inspiratory time or inspiratory flow rate can be used also to deliver the breath more slowly. That can often get you a few points off on the plateau pressure. Your inspiratory flow waveform, a decelerating waveform. And then, of course, addressing any air trapping or auto-PEEPing issues that you may have. And I'll talk more about auto-PEEPing and air trapping in a moment. So your driving pressure. So this is one of the pressures that over the past decade or so we know is also implicated in ventilator-induced lung injury. It's a difference between your plateau and your PEEP. Your plateau and your PEEP. Okay, so there again, the plateau comes into play. And you think about the term driving pressure. So you think about your baseline is the PEEP. The driving pressure, it's the pressure to drive that breath in, but not including the resistive component. Okay, so that plateau. And it's comprised of two pressures applicable to the lung itself, the transpulmonary pressure gradient or change, and that applied to the chest wall as well. Current suggestions are to maintain driving pressures below, not at or below, but below 15 centimeters of water. The management strategies are essentially similar to those for monitoring or managing plateau pressures. That's not surprising, because plateau pressures are a major determinant, except where increases in the PEEP result in lung recruitment. So in some cases, you can actually increase PEEP, increase your baseline. And what happens is you're recruiting lung, you have recruitable lung, and your, if you will, your driving pressure will not increase concomitantly. Okay, it may not increase at all. It may stay stable, because you would think you increase your peak airway pressure, your driving pressure, but in some cases where you're recruiting that lung, okay, that volume is able to go somewhere. Okay, the volume is able to go somewhere. You've now recruited the lung. You now have more area in which you're putting that tidal volume. And according to Boyle's law, you're putting the same volume into a greater capacity, for the pressure should basically come down. This is just a depiction of really kind of the relationship. All the way on the left-hand side, you actually have, you basically have, your baseline pressure, and then you're actually coming up, you're doing the resistive component is what I alluded to before. It's the difference between your peak, in this case, it's 50 centimeters, and your plateau, which in this example is 40, okay? And you're really showing you the alveolar distending pressure, your driving pressure, the difference between your plateau and your baseline PEEP. And then you have your sample calculations, again, delineating, lung compliance versus the resistive component as well. So basic strategies for monitoring or managing pulmonary mechanics. So static compliance, decreasing your tidal volume to 6 mLs per kg if the ABG permits. I'm kind of lying to you a little bit. ARDSNet basically says you go down to 6. If 6 doesn't do it, and the patient can, relatively speaking, tolerate it, you can go down as low as 4. Okay, as low as 4 mLs per kg. So for someone such as myself, my predicted or ideal body weight is between 75 and 80 kgs. Okay, I'm a little bit heavier than that actually, but so let's just make the calculation easy and say that my predicted body weight is about 80 kilograms. And then if you're going at 6, okay, at 6, that you're basically looking at a tidal volume of about 480, something along those lines. At 4, you're looking at a tidal volume in the 300s. Okay, so at 4 mLs per kg. So compared to the tidal volumes that we used to use, someone such as myself 25 years ago would probably get a tidal volume of 650, sometimes even 700. Typically, that's not done. Again, just things you can also do with regard to body position, particularly if a patient has a ascites, a swollen abdomen, or they're simply like pear-shaped, and they have a lot of adipose, they have a lot of tissue that's in the belly. You can offload some of that just by positioning the patient. It's not unusual to be able to gain 2, 3, 4 points off of both your peak airway pressure as well as your plateau pressures. Resistance, you really need to look at, well, is it an issue of an artificial airway that the tube is a 7 versus an 8? Is it an issue of the biofilm that can build up in the inner lumen of the artificial airway? You use a wiper catheter, or, again, there's different manufacturers that are out there. Basically, you're if you will, harvesting the biofilm. You're at least 2 advantages there. You're increasing the lumen, the inside lumen of the tube. The second thing you're doing is you're minimizing the amount of that biofilm that's the emboli, it's actually called, that goes down into the lungs and can cause either an initial or a further a subsequent infection in the patient's lungs. The airway diameter, so the anatomic airway bronchodilators, things like suctioning can also be beneficial in helping address the resistance. So let's take a look. We've talked a little bit about pressures here. Let's take a look at some graphics. They're related. They're obviously not the same thing. And broadly speaking, there's at least 2 categories of graphic displays. So scalars, anytime you hear the term scalars, are waveform representations of pressure, flow, and volume on the y-axis, and on the horizontal axis, or the x-axis, is you actually have time. You have time. The loops are also can be useful, and they're representations of pressure versus volume, or things like, or parameters like flow versus volume. And I just have very quick examples, of a scalar on the left hand, bottom left, and basically loops on the bottom right there. We'll again take a deeper dive. So volume control versus pressure control. So in order to kind of have an idea of what's maybe not normal, let's look at what would be relatively speaking, what would be normal. And a little bit tough to see here, but the top, in the green there is volume. In the magenta or pink is flow, and in the bottom yellow is pressure. Okay. And just to quickly point out a couple of things here. So what you have on the bottom right, if you will, is you actually, in pressure, you actually have a pretty kind of a level amount of pressure there. It's not ramping up. It's not an accelerating pressure like you'd have with volume ventilation. It reaches its peak, it levels off, and then it goes to actually a release there. Because with pressure control ventilation, it's usually a time cycle that's involved. So just by looking at these, not only this is what they look normally, but they can also help you distinguish what mode that patient is actually in. So the uses of the waveforms are many. Obviously, we don't have the time to go into each and every one in great detail today, but broadly speaking, you can look at like 3 major categories of the value that waveforms can provide to patient care, particularly with your mechanically ventilated group. So abnormal ventilator parameters and lung mechanics could be one. So things like over distension, things like auto-PEEP. In the middle portion here, patient-ventilator interaction. So patients that have insufficient flow, where there's asynchrony issues, things along those lines. And then you can have vent circuit and artificial airway issues, secretion buildup in the circuit, in the airway. You can also have things like leaks as well. So detecting, common, we're focusing today, common abnormal events. So the scalars, where you're looking at time in the horizontal axis, is really looking at the potential for trigger and sensitivity issues. Also looking at things like auto-PEEP or air trapping. And then looking at some of the more common forms of patient ventilator dyssynchrony or asynchrony. And then some of the loops that we're going to look at is what you might see in overdistension, and what also might be helpful in looking at a pressure volume curve in actually setting PEEP. Again, I alluded to that as I started the presentation, but to give you guys as clinicians some guidance, and the physicians and nurses that you work with some guidance on, well, let's not be arbitrary about this. Let's kind of look at what's appropriate for the patient. So some trigger sensitivity or sensitive problems. Patient could not trigger a breath. So the example in A is, you're seeing this middle kind of dotted, the missed effort there was the patient's actually sucking. You see pressure, you see a dip in pressure, you see a dip in flow, but they're not actually getting the breath. So, clearly an issue. And then excessive on the right-hand side for B, the excessive effort to trigger a breath. So the patient's having to suck too hard. So that if it's a flow trigger, that the flow, or if it's a pressure trigger, the pressure that the patient has to generate to initiate a breath is too great. The work of breathing has increased. I will tell you this, that, pretty much, 25, 30 years ago, the infant ventilators were becoming flow triggered almost universally. And it was recognized that a flow trigger imposes less work of breathing on a patient. And then a few of the vent companies and a few of the academicians that work with mechanical ventilation said, well, if it's good for infants, why not adults and older pediatric patients? So pretty much you'll find that, whereas 30 years ago, a lot of the adults were being set up on a pressure trigger of, let's say, -1, 1.5, sometimes even -2 centimeters. Now it's pretty much a flow trigger, and often setting the patient up on kind of a default or a guideline, if you will, of basically deflecting 3 off of that bias flow in order to trigger a breath. There's exceptions to that. Sometimes when you're weaning a patient, you have them on pressure support. It's not necessarily a terrible thing, particularly early on in the weaning process, maybe to kind of lower a flow trigger from 3 to maybe 2 or 1, as long as obviously they're not auto triggering. Detection of auto-PEEP, probably what's most significant in the top. And so you're seeing flow, okay? And below the dotted line, the top scalar, below the dotted line is actually what's going on as far as on the exhalation side of the equation. What it's showing you is that flow has not smoothly returned to baseline, okay? It is not smoothly returned to baseline. So it's actually abruptly, the patient's still exhaling, and it's abruptly going into inspiration. And this can be it can actually contribute to asynchrony. It can basically contribute to overdistension. We now know that auto-PEEP is not a good thing to have with a patient here. So you kind of see that depiction there, now encircled by the red line. Patient still exhaling, boom, went into the next breath. So, some of the fixes, just to kind of maybe get ahead of myself a little bit here, some of the fixes that you can really look at there is, obviously you want to look at the patient's, ABGs, because you don't want to start changing a lot of parameters. You fix auto-PEEP, but you hurt them somewhere else, type of deal. But many times with most ventilators, most adult ventilators, exhalation is passive. So, you're setting obviously your tidal volume, you're setting your inspiratory flow, and what's left over is for expiration. But some of this can be fixed by doing things like, if you will, shortening the I time. Okay, and that may mean giving the breath quicker. It may mean in, let's say, your VC plus or some of your dual modes, it would be actually setting your eye time, a faster eye time, if you will. So some of it can be fixed if it's a setting related thing. Some of it, if it's related to maybe the patient's bronchospastic, where they have excess secretions, things along those lines, it can be fixed by, delivering bronchodilators, by suctioning the patient. If there's an issue with the tube, the endotracheal tube having excessive buildup in it or being partially kinked, something along those lines, it can be addressed by troubleshooting in that manner. Auto-PEEP measurement. So whereas your plateau pressures are an inspiratory pause, you would perform an expiratory pause maneuver in order to measure your auto-PEEP. Typically if a patient's on 8 or 10 of PEEP, and then you actually do an expiratory hold or expiratory pause, and you see that you're actually measuring, if they're on 8, you're 8.3 or something along those lines. That's really relatively insignificant. It's when your auto-PEEPing or your air trapping is in excess of 1 to 2, it could become problematic. Basic strategies, I alluded to a few of these, but adjusting things like an inspiratory time or flow rate. So eye time, if it's dual mode, I'm use the example of VC+, but it could be pressure regulated volume control. Increasing the airway size. I don't know that you're really going to use a tube exchanger or reintubate the patient for something like this, but it may be, again, the wiper cath, keeping that the inside lumen as clean as possible. Inspiratory flow, so increasing your inspiratory flow in order to deliver that breath, more quickly, as long as it doesn't affect your other parameters, notably, your peak airway pressures, your plateau pressures, things along those lines. Treat the bronchospasm, suction the patient, address any asynchrony or desynchrony issues. Sometimes it's just the patients come up from the ED and they're not adequately sedated, and they're breathing over the vent, and it's not the setting, it's the patient needs to be quieted down. They need to be initially sedated, and I'm not one for sedating our patients until the end of time. But when you first get the patient, in order to manage them, in order to kind of see where you are setting wise, in order to help minimize the chance of a tube dislodgement, just overall patient management, they really should be sedated. If the patient continues along those lines, and then they're getting really poor ABGs in addition to the asynchrony, and they're sick, I'm saying they're really, really sick. Maybe they have septic shock, maybe they have ARDS, things along those lines. A lot of those patients, they end up being paralyzed, chemically paralyzed, so that we can actually manage them. You take asynchrony out of the issue, and many times in doing so, you're going to take the auto-PEEP, if they have it, out of the equation too. So flow desynchrony. What I do want to say about desynchrony in general, there's many causes. Okay, and I have one of my subsequent slides here. I show you other causes than simply flow desynchrony. I just want to kind of emphasize that, because it's not like our chief medical officer basically says desynchrony is a garbage term, and I said to him, "What do you mean it's a garbage term? You take it out on Sunday nights, put it by the curb," and he goes, "No, it's not like garbage." But he goes, "There's so many different causes to it." But I says, just you and I talking. Aren't there like, okay, there's a lot of causes, but aren't there like, isn't there a short list? And he's kind of agreed. He's a pretty bright guy and stuff like that. I've had some interesting. He's smarter than I am. I've had some interesting debates with him and stuff. But in any event, well, let's take a look at flow desynchrony. So adequate flow shown by a linear increase, pressures. That's the A. That's the top one. And then, but basically on the bottom one, or B, you're actually seeing, it if you will, scallop to some extent. So it really looks like the flow is inadequate. I also do some work with preparing new graduates to take the MBRC exams. And it's going to sound a little bit lame, but one of the things that I actually do is, when you're looking at a flow, or airway pressure or flow scalar, and it looks notched out, and you're just stressed out, and you're totally like, don't know the answer to it or whatever, about half the time the MBRC is looking for you to increase the flow. That it's a flow starvation issue. I know that sounds a little bit lame, and we shouldn't be arbitrary in troubleshooting and things along those lines, but sometimes it's actually what it is. Particularly if you're in a mode where you're not, where it's not an eye time issue. And then this slide, a bit busy, I admit it, okay, but this gives you an idea of four of the causes of dysynchrony or asynchrony. And it goes into a little bit on how you could recognize it, it talks a little bit about, some of the, some of the manifestations, and again, some of the basic causes as well. So what's going on physiologically with the patient, but also, some of the causes as well. And, by looking at the causes, if you can kind of reverse some of those, you can also, they can also be, if you will, solutions to helping address them. This synchrony, again, there's so many different types. So it's really a divergent fix. So it's not one thing that we're actually doing, but if the cause is agitation or delirium. So agitation is what you might get with a new patient you got from, let's say, the ED. Agitation might be what you get when you're giving a patient a sedation holiday to attempt a spontaneous breathing trial, as we should be doing with most of our mechanically ventilated patients. Liberating them early, it almost negates this presentation overall. Get them off safely, etc. But we know that some of them they're not in a position to come off. So agitation could be, again, they came up from the OR, they came up from the ED, they're agitated, we need to get them settled in. Delirium's different. Delirium is maybe they've been in the ICU for a long period of time, and their circadian rhythm has been really disrupted. And, so delirium is actually a common affliction. And a patient, by the way, does not have to be combative to be delirious. There are forms of delirium that are quiet forms, okay? But it can still be, whether it's a quiet form or they appear, outwardly, agitated, outwardly delirious, it can be one of the major contributing factors to or dyssynchrony. If stable, switch to pressure support, possibly extubate them, decouple. What we do, it's, pull and pray is what, some people call it. But basically, you have a patient who, when you lighten their mechanics are decent, their blood gas are decent, their x-ray looks okay, they're not fluid overloaded, they're not septic, lions and tigers and bears, oh my. They're none of those things. They're a candidate potentially to be extubated, but when you wake them up, they go completely, maybe you decouple the spontaneous awakening trial and spontaneous breathing trial. You wake them up and you pull the tube. It's not, it makes sense for certain patients, though not all. Trigger sensitivity. So switching to a flow trigger, but again, flow triggers are much more common than pressure triggers today. Adjust the inspiratory time and inspiratory flow, and it really is getting your scalars up there. Pulling the scalar up and adjusting it, adjusting your I time, maybe for, to allow for more E time. So, if you will, shortening the I time, increasing the flow, so delivering the breath more quickly. Auto-PEEP can also be one of the causes. So auto-PEEP is a problem in and of itself, but it can then cause concomitant issues. So addressing the auto-PEEP by, the measures that I talked about earlier on. And again, bronchospasm may be one of those, may be separate. So the patient could have bronchospasm, but they're not auto-PEEPing, or they could have both. So in addressing patients who could benefit from bronchodilators. I personally think that, there's a chunk of patients that are still receiving bronchodilators that needn't have them, or maybe they need a PRN type of deal. But it's, it was true 30 years ago. It's true now. There are some patients that can absolutely benefit from bronchodilators. And it's something that if they're wheezing, if they decrease breath sounds, if they have a history, they're on a home regimen, et cetera, then it's something that you should be, mindful of. Now let's take a look at some pressure volume curves. Some people will actually call them compliance curves. Okay, so on the vertical axis you have volume, on the horizontal axis you have plateau. Okay, and if you will, the example that's on the top here, so top right hand side there is, I'm going to call it more normal. Okay, so more normal compliance. Okay, the one in the middle is low dynamic compliance, okay, where you think about what's going on here, where you're basically, for every increase in volume, for every increase in volume, there's a disproportionately higher increase in pressure. That would be low compliance, okay, versus a patient that has a saggy lung. So the high compliant patient may well be a patient who has like severe emphysema, that the elastance of the lung has been reduced, okay? So that ability for that lung to kind of spring back, it's a saggy lung, it's an emphysemous lung. So you would actually have the opposite. You'd have, for increase in volume, you have a disproportionately lower increase in pressure. So again, it can be potentially valuable, not just in determining, things like compliance, high compliance, low compliance, but also these curves, and I'm going to show you in the ensuing slides, can also be helpful in trying to actually set your PEEP. So adjusting PEEP levels. This is not the only determinant, okay, that you should use, but it is kind of important. In some of those patients, when you pull up a pressure volume curve, you can actually see at the top portion of the curve, you can see what looks like a bird's beak, crudely. Looks like a bird's beak. And it's suggestive that you're over distending the patient's lungs, that you're getting an increase in your PIP, your pressure, but you're not when the top of that beak is basically, horizontal, you're not getting any increase in volume. It's all about, you're just increasing pressure. Think of a balloon, okay? A balloon is hard to get going, when you're trying to inflate a balloon. It's hard at first, and then it's kind of okay in the middle. And then when you're at the very end, it gets harder again, okay? Your lungs, it's not a great analogy, but it's also not a terrible one. You want to aim for that sweet spot, okay? You're going to have to initially, you're going to have to, inflate the lung. It's going to be hard at first, but you don't want it deflating all the way, okay? Because what we know is that PEEP is not just a tool to enhance oxygenation and prevent atelectasis, okay? It's also a tool so that the lungs don't empty and you reduce the shearing pressures. So you reduce those shearing pressures that can actually cause or worsen an inflammatory cascade that can ultimately end up in a stiffer lung, contribute to ARDS. So the point I'm making is that, okay, so you want to avoid that upper of the beak on the upper portion, okay? The other thing that you want to do is you want to look at your inflection points. And in some cases, the lower point, so lip is lower inflection point. The UIP is upper inflection points. Sometimes they're called deflection points, okay? Let's not get semantical. So you have your lower inflection point, your upper inflection point, and they're drawing tangents. The green line in the middle, you're kind of drawing a tangent where you see at some point early on, you're getting more volume for each concomitant increase in pressure. So that's where the balloon gets easier to blow up, all right? That gives you some guidance as to where PEEP should be set. It's not 100%, but it gives you some guidance, okay? That a centimeter or two above that is not a terrible place to actually set your PEEP. In this case, it would be crudely around 7 or 8 of PEEP, okay? And again, the upper portion, trying to set your volumes in order to minimize that bird's beak. This is showing you a figure 8 pressure volume curve. So very, very different, suggesting that patient's inspiratory flow exceeds that which is set. So they're sucking in, okay? But it's just not, the machine is not giving enough. So it's actually creating this negativity. So you actually have, notice, the significance isn't just the figure 8, but you're actually the patient in their pressure is actually not going back to 0, they're going back less than 0. So they're sucking on the actual artificial airway, and they're creating negative, negative pressure there. The fix here, just everything's obvious if you know it. The fix here would be, either increasing the inspiratory flow or switching to a time cycle and if you will, reducing the I time. Basics of a little bit of kind of consolidating some of the prior points that I made, basics of utilizing pressure volume curves. So if overdistension is suspected at the upper inflection or deflection point or beak, reduce the tidal volume as tolerated per ARDSNet, reduce the inspiratory flow or increase the I time. If it's a figure 8, increase the flow. You can also manipulate the I time with that as well. If it's insufficient PEEP is suspected, consider increasing the PEEP in 1 to 2 centimeters above the lower inflection point as tolerated, okay? So the studies that are out there are saying when you do increase PEEP, do it in increments. So it's called an incremental PEEP study. So PEEP is often incrementally increased, okay? And You're looking at various parameters. Well, how much? You're looking at oxygenation. You're also looking at hemodynamics, because at some point you're going to increase your PEEP so much it can actually, compromise, as I have in this slide here, it can compromise the patient from a hemodynamic perspective, mainly because you're impeding venous return, but also because the lungs are really getting quite inflated at baseline and they're tamponading, they're squeezing the heart, if you will. And then again, if you're doing that, you're monitoring the patient for adverse responses. Again, hemodynamics and looking at your driving pressure as well. So PEEP, generally, it's incremental tidal volume. It's often, if you will, decremental, where you're coming down in order to achieve, kind of the delicate balance of adequate ventilation and oxygenation, but at the same time, coming down on that in order to manage your pressures, your plateau pressures and your driving pressures. Let's look at some cases and then we'll kind of wind down on this presentation. So 54-year-old, 5'10", 250-pound male, post-chest trauma. So before we go on, let's just say, so he's 54 years old, about average, slightly above average height, 250 pounds though. Okay, so this patient's predicted or ideal body weight, which should probably be about 75 kgs, give or take. Okay, so post-chest trauma, patient day 7 of mechanical ventilation with settings of, AC 560, 20, 60% and +8. ABG 7.44, PCO2 is 35, PO2 is 61, bicarb is 26, SpaceX is +1, and SATs are 91. Peak airway pressure is 37, plateau is 31. Okay, so I'm looking at this blood gas. By the way, so one of the other pieces of guidance that ARDSNet gives to clinicians is that 55 keeps them alive, crudely put. So a PO2 of 55 is not the endpoint, but it is generally adequate to properly oxygenate the patient, with the proviso that their hemodynamics, that their blood flow is adequate, that their blood pressure is adequate, and things along those lines. Okay, so we're looking at, again, 7.44, 35, 61, 26, et cetera, et cetera. So what recommendations would you make regarding vent settings to enhance oxygenation, manage airway pressures, and why? Okay, so something to look at. Okay, you got a plateau pressure of 31. Okay, is one of the things you can look at is actually coming down a little bit, very slowly, but coming down on the tidal volume. It really looks like, per the patient's PCO2 is 35. Okay, so you got room. If it goes up to 40, 42, things along those lines, you have room there. So again, this patient's, understand that this particular patient is ideal body weight is somewhere around 75 kgs. So clearly that they could tolerate, at 6 mLs per kg would be somewhere in the range of about 480, 500, something along those lines. So you go from 8 to 6 to about around 450. That's a reasonable approach. Increase the PEEP to 10. Repeat an inspiratory pause and see where you're at, because again, it's possible the driving pressure, by the way, does not become problematic, particularly if the patient has atelectasis, and by going up on the PEEP, you're recruiting some otherwise atelectatic lung. Possibly reduce inspiratory flow or increase the I time to achieve about a 1 to 2 IE ratio in order to minimize any sort of air trapping. Case 2, younger, 21-year-old, 5 foot 5 inch, 120-pound female. Status, pardon me, status asthmaticus. I know that Kenny and some of the other presentations that go along with these has made some descriptions of asthma in some of our other presentations. So status asthmaticus, recently intubated for impending respiratory failure. Vent settings are AC 350, 24 respiratory rate, and 40% and +5. ABG 7.39, so a normal pH. PCO2 is also normalized at 42. PO2 is 76, bicarb is 24, and base excess is 0, 95%. Peak airway pressures, however, are 39. Plateau pressures, approximately 26. So just to pause for a moment here, we're looking at patients, again, peak airway pressures 39, plateau pressures are 26. Again, I don't know what the patient's inspiratory flow is. I will tell you this though, that it's probably reasonable to say that the patient's airway resistance is greater than 10 to 12. Okay. Expiratory pause indicates that her intrinsic PEEP is 10. So what recommendations could possibly be made to the attending physician to reduce the auto-PEEP and improve the ventilation on this patient? Patient's blood gas, from a ventilatory perspective looks decent, okay? But what we know is that things like the peak airway pressures are high and the resistance is high. So with the patient's diagnosis, recommend a continuous albuterol perhaps at 10, 15, or 20 milligrams per hour would be a reasonable way to go. Decrease the inspiratory time. So really trying to achieve an I to E ratio, longer E time to minimize. I don't know that you're going to eliminate right now, but to minimize if the intrinsic or auto-PEEP. Increase in the inspiratory flow. So it's really, you're increasing the flow again with both decreasing inspiratory time or increasing the flow. You're accomplishing a very similar phenomenon, giving more time for exhalation. Suction the airway. If it's not unusual for patients that have status asthmaticus to have mucoid secretions. So the secretions, purulent secretions are infected, they smell, they look nasty, whatever. Your patients that are a straightforward, not a good diagnosis, but a straightforward status asthmaticus, they're probably going to have mucoid secretions, maybe a lot of them. It's very kind of viscous. They can look clear or white, relatively benign, except the patients can have a lot of them because some causes of asthma are allergic, and part of that allergic cascade involves excessive secretions. So suction the airway is a reasonable approach as well. Heliox, not a terrible approach either. 70-30. In this particular case, I'm looking at the patients on 40% oxygen. One of the delimitations to Heliox is patients that require, I'm going to say, higher than 40% oxygen. Again, 60-40 exists. It's not commonly used because once you get above a 70-30 mix, where you're actually giving more oxygen, the if you will, low density characteristic of Heliox starts to really wane quickly. So because it's such a low density gas, 70-30 or 80-20, it's able to if you will, reduce the work of breathing, and you're not really reducing the resistance per se, as far as from the standpoint of the patient's anatomy, but you are, because the gas is actually thinner as well. So for this patient, certainly consider a 70-30 mixture. Just keep an eye on the SATs. SATs are 95 now. There's a lot of data out there that basically says that we're probably over oxygenating a lot of our ICU patients. Not all of them, but that it's reasonable to target, a SAT of 90 to 92 for many of our ICU patients is generally quite acceptable. Okay, and there's what's called the ICU oxygenation study, which really looked at oxygenation, looked at outcomes. And they found that outcomes, including all-cause mortality, by targeting a slightly lower, if you will, range for things like saturation and PO2, the outcomes were better for those patients. One of the subgroups where it was not is your head injury patients. They typically do better with a slightly higher, even a PO2 north of 100, but south of 160, 180. Some of those head injury patients, a bleed or a trauma, can benefit from higher oxygenation. But many of our other patients were over oxygenating, and we're doing all that stuff we learned about in respiratory school, or if we have any nurses that are watching this, in nursing school, they can all occur. Free radicals, inflammatory cascade, absorption atelectasis, things along those lines can all be things that we don't necessarily want. So ways that you can actually achieve some of that, address this patient status asthmaticus while, accepting a SAT of maybe 92 or 93 because you're giving them a slightly lower FiO2 may not be a terrible way to go. Manually decompress. So I've seen this done. Some of our intensivists do it. You're not fixing the problem, but you're buying the patient's time. So if you're doing some of the other 5 things that are mentioned, manually decompressing the patient by taking them off, can buy you time. It should not be the only strategy that you're doing, because obviously you're taking the patient off, you're breaking the circuit. It's an infection risk. It's you're reducing their ventilation. You're potentially reducing their oxygenation. So, it's something that you just, you can keep in mind as an interim measure. Lastly, addressing dyssynchrony or asynchrony. 45-year-old, 5'8" 195-pound male, a status post exploratory laparoscopic surgery resulting in a uncomplicated bowel resection. Sounds like a patient needed surgery, but it sounds relatively straightforward. Vent settings, VC 450, rate of 20, 40% and +8. ABG 7.37, looks like a good acid-base balance. PCO2 is 38, also good. PO2 is 112, a little high, but not alarming. The bicarb is a little low, 20, and -2 for your base excess, and saturation is 99%. Peak airway pressure is 32, plateau pressure is 24. Actual respiratory rate is 32 breaths per minute. So really what we're saying is we've set the patient at a rate of 20, but they're breathing at 32. So they're really over breathing it considerably. So the ABG is really reflective of that over breathing as well. The heart rate, patients in sinus tachycardia, 120. So, not terribly high, but I would kind of, in the back of my mind, want to know where this patient resides. If they normally reside at 65 and they're 120, I'm more concerned. If they normally reside at 95 for a heart rate and they're 120, patients under stress, and particularly if they're in, the recovery room or they're in the ICU, they're under some element of stress. They've just been operating. The RAS score, so the patient is alert, maybe a little bit agitated. What recommendation could be made the attending physician in order to help address the asynchrony? So some of the things we look at, decouple the spontaneous awakening trial and the spontaneous breathing trial. So this patient, you wake them up, they want to get extubated, they know what they need, etc. And we don't want them pulling their own tube out type of deal. So it's really just wake them up, pull the tube, monitor them very, very carefully and things along those lines. Consider extubation. So, that's kind of goes along with the first one as well. And lastly, I want to share with you some references that may be beneficial. So Bob Kaczmarek, God bless his soul, one of the mentors of mine and a friend, passed away fairly recently, but 12th edition of Egan's Fundamentals has been out for about 9 months now. That's an excellent source, and there's some very good chapters in there done by Bob Kaczmarek, but also done by Rob Chatburn. Have some good information that's out there. As well as there's some sources here on ventilator graphics, scalars, loops, secondary measures, and then another that talks to ventilating the severe asthmatic patient. So also, this, again, the NIH National Heart, Lung, Blood Institute really houses, if you will, the ARDSNet information that's out there. So I encourage you to avail yourself of that as well. I want to thank you guys very much for attending this particular lecture. Hopefully you enjoyed it and got something out of it, and hopefully you'll come back to us. Thanks a lot and have a great day.